it's not supposed to change that way. So when it starts changing that way, it doesn't follow the right pattern. And that over time can lead to adenocarcinoma or cancer of the lower esophagus.
Right, so for our viewers, reflux disease itself actually is a risk factor to develop cancer of the food pipe.
Absolutely.
And it starts off often as what we call Barrett's esophagus. And so Barrett's esophagus develops in, say, a 50-some-odd-year-old gentleman who we bring in for an endoscopy one day. We do the endoscopy, takes a few minutes. We look inside, we find the Barrett's. We take a biopsy. If the biopsy shows Barrett's, plain old Barrett's, without any advanced features that say, hey, listen, this is going to become a cancer soon, what is the next step? How are you treating this gentleman? What is the surveillance that you might do? Tell us how you're going to make the plan of care for this type of a patient.
Most of the time, it's suppressing the acid. So if they don't have a little bit of the stomach slipping up called hiatal hernia, or I usually put them on PPI, like omeprazole or Prilosec, Nexium, whatever it is, to suppress that acid. And usually, because the constant acid exposure is the one that tend to make it into cancer, once you suppress that, you can just follow by doing routine endoscopies every 3 to 5 years. I like to be a little bit more conservative because if we can catch anything early and take care of it, that's better than pushing it off to a little bit later. So I would bring them back, I'd see how they're doing with their symptoms. Sometimes they have no symptoms, so I just follow them, and then every 3 years I do an endoscopy.
Yeah, I agree with you. Every 3 years I bring them back. If there's a change in the symptoms also, I'll do an earlier endoscopy.
Definitely.
You'd agree with that, right?
Yep.
The sensation of food sticking.
That's a
an
difficult one.
alarm.
Yeah, that's a big alarm sign. So anytime they say there's food sticking, I'm noticing I'm getting weaker, and at the same time I have low appetite and
Weight loss.
weight loss. All those things, those are very big alarm signs. So I got to differentiate at that time. Is this acid coming up and causing narrowing or strictures, as we call it, or is this turning from Barrett's into the cancer that we have?
Right. So I in my practice, if there's any of these alarming features, and we call these red flags,
Yep.
alarm features, difficulty swallowing, the sensation of food sticking, I bring them back right away.
Yep.
That could be a sign of cancer. And that's even without Barrett's esophagus. If a young patient shows up and has difficulty swallowing, we do an endoscopy. Yep. And the reason is also there's a condition called EOE, eosinophilic esophagitis. We should touch on that for a little bit because we probably have a great deal of young viewers out there. And this is a disease I tend to find quite a bit in young people. Tell us a little bit about EOE, eosinophilic esophagitis. Have you seen it at all?
Oh yeah, lots of times. Majority of the time, the patients who come in, young kids don't really come in with heartburn. They don't want to say they have heartburn. They don't want to say that, even if they have something sticking, they don't want to come in to see a doctor.
But they're also the first ones to admit that it's after eating a heavy meal from the food court at the mall. Or
Definitely, definitely. And most of the times when I see these patients, they come into my ER saying something's stuck and I can't get it out. It's a food impaction they're having. So I'm going in the middle of the night trying to retrieve whatever food is getting obstructed. When we relieve it, we look at the mucosa, the lining of the esophagus, say, this looks a little bit abnormal. We take biopsies, and that's when we see lots of eosinophils.
These are the red, they light up red on the microscope.
That's right.
Cells, yeah.
These cells, and these cells are predominant in this situation. Now, it's interesting because there's something called PPI responsive EOE or plain old EOE.
That's the fork in the road we deal with.
That's right.
Which is patients who get better with Nexium.
Nexium.
And the EOE goes away, and then there are the folks where it doesn't go away.
That's right.
And that's tough to treat. What are you doing right now with your EOE patients? They come into you after meeting in the ER, you took the biopsies, you tell them, hey, listen, you've got this disorder. What's the next step? How are you going to treat them?
So initially, right after the food impaction, I don't want to do anything because I want them to heal a little bit in that area. Then when I bring them back to clinic and we got the biopsies and everything, I'll say, let's try to avoid some foods. Again, I always try to do natural stuff, lifestyle modifications, see what it is. Right. And we know there are some things that really can exacerbate EOE. This includes nuts, milk, egg, and there's a soy is another big one.
Yeah.
So all these things. So we try the elimination diet. At the same time, I tell them should also go and meet an allergist to see what other food allergies you have. Maybe that could be exacerbating this as well. And then I start treating them from my end. And usually we use light steroids, topical steroids. Sometimes you might think that they have asthma, they're using inhalers, but they're not inhaling it, they're just swallowing it. And that steroid that's in those inhalers, whatever, when they swallow, that coats down their esophagus or the food pipe and really gets into that area.
The steroid reduces that inflammatory response. I always get a phone call from the pharmacist when I write the prescription,
Yes.
swallow the inhaler,
Yes.
wondering if I'm crazy. And I always tell the pharmacist we're treating EOE.
Yeah.
I often send them an article to update because it's an unusual way to take an inhaler. The patients actually puff the steroid, and instead of inhaling it into the lungs, we swallow it to treat the EOE. I like your point about the allergist. I always refer the patients to see, because this obviously was stirred up by something.
Yep.
And it would be nice to figure it out. With adults, it's really hard to do elimination diet to restrict these food products, because they're often in many of the food products that we eat.
Yep.
So EOE is another thing we might find in patients. Barrett's we might find.
Yep.
Let's move on to something that I know you want to talk about today, which is when someone has difficulty swallowing or pain in the chest, sometimes we find a condition called achalasia.
Yes.
To educate us on this word that many of our viewers probably have never heard.
Well, achalasia is basically a Greek term, and where it says it's a failure to relax. And this is what happens when our food relax of the esophagus.
Most of us New Yorkers have a failure to relax, right? But this is a
That's
failure of the esophagus. Which part?
So the lower part of the esophagus, which is actually what we call the sphincter, which should be working well to prevent reflux, is working a little too hard where it's not relaxing.
The valve is clamped down.
The valve is clamped down.
Right.
So when the food comes down, it should open up and let the food enter from the esophagus into your stomach. When it doesn't do that, you start building up. It starts getting pressure. And then after a while, it'll go down because it's a physics thing. The pressure on top is higher than what's holding here, it'll go down. As it gets worse and worse, that's when people will start coming to you to figure out what's going on.
I've been called in the middle of the night to the ER. I've had to take patients for endoscopies, and they don't know the diagnosis. And to get one little piece of chicken out when someone gets that stuck is actually a little bit easier. When it's achalasia, the entire esophagus can fill up.
Yes.
And the sphincter is very hard to overcome, and we can spend hours pulling food out of the esophagus. And I've been there in the middle of the night. I remember one case from 2 to 4 o'clock in the morning, evacuating the esophagus. What are some of the treatment options out there that you can offer patients with achalasia?
So first thing I always try to do, even with achalasia, is this achalasia or pseudo-achalasia? And I think this is very important, because when we go in there, we feel like, oh yeah, it's tense in there. We're trying to push through to come into the stomach with the endoscope. And then I always want to rule out, by first thing, just doing an endoscopic ultrasound or a CT scan to make sure they don't have cancer there that's mimicking this disease of achalasia.
A tumor can actually present very similarly. Patients can have the same exact symptoms.
So once I do an EUS or CT scan and I don't find anything that I'm concerned about, then I say, well, you have achalasia. Let's try to identify what type of achalasia you have. There's multiple types. And once we identify, we do something called a manometry. It's like a pressure curving and seeing how you swallow. Once we identify, we say, first thing, if you don't want to be too aggressive, we can try Botox. And you're thinking, Botox, when I give that into my face, what are you doing?
I know when I inject it in the clinic and I'm doing an achalasia patient, the nurses always joke around, can I have the extra for my wrinkles?
That's right.
And they're wondering, why are we putting Botox in the esophagus? But it actually can help with achalasia.
Exactly.
What about other options where we're more invasive, where you can actually cut the problem, the muscle that is causing the problem? Tell us a little bit about that.
Well, in the old days, until the last 10 years, I would say the gold standard would be something called a Heller myotomy. A surgeon comes in, he cuts the muscle laparoscopically or open, and then relieves that tension there so all the food goes down.
You can do this a lot different now,
That's
correct?
right. It's changed, it's a night and day from what it was 10 years ago. Now, endoscopically, we can go into the layers of the esophagus through the mouth without any cutting from external areas.
No scar.
No scar. Go in from there, make a tunnel, we call it, in the esophagus all the way down to the stomach, and cut that muscle that's really tight there, open it up,
I've seen
and come
this.
out.
It's incredible. It's
It
incredible.
is.
And it works.
It's amazing.
It's called a poem.
A poem procedure.
It's not a literature, it's not in a book, it's not a fun poem to read. It actually stands for something. Tell us what it stands for, poem.
Poem means per oral, that means it's going through the mouth. Endoscopic, with the endoscope, we do a myotomy, which is cutting the muscle.
Right.
So we make it look like poetry in there.
Yeah,
but
it does look good. It's incredible what can be done for achalasia now as compared to maybe even 10 or 15 years ago. We covered a lot today about upper gastrointestinal symptoms. We talked about heartburn today. We talked about reflux. I think we really covered a great deal for our viewers today. The most important part is those alarm features. And in our last 30 seconds here, let's go over that again. What are some of the alarm features where a patient should run right away and come see their gastroenterologist?
So if they have difficulty swallowing, they're having weight loss, they're fatigued, they have low appetite, and anemia, any of these things that are there, that's the first thing you do. And if you're above the age of 50, and especially this is common in white males, come get checked.
Yeah. So we really covered a great deal of gastroenterology today with Dr. Guram. Thank you for checking in and viewing our latest episode of Medcastplus. You can visit us on our website, medcastplus.com. Remember, the topics discussed today do not replace your meeting with your primary care or gastroenterologist. These are just to help educate, but not to direct your care. If you have any significant symptoms or medical issues, please speak with your primary care doctor. This is the best way to cover yourself and make sure that you're not missing any significant diseases. You can reach out to us on social media or reach us by phone at 718-510-2103. I'm your host, Dr. Jack Braha. Thank you for viewing. Stay well, stay healthy, Brooklyn, and goodbye.